So, good afternoon, good morning, students. Today we will have a clinical case discussion. Initially, what we do is we'll revise certain aspects of neuroanatomy, neurophysiology of spinal cord for about 15 to 20 minutes. Then we'll have a case, and during discussion, you will be asked questions which you will have to answer. If you concentrate on what is being taught in the first 15 to 20 minutes, then the much more to answer the questions. So here we go. Right. The spinal cord is in the vertebral, bony vertebral canal, and it is surrounded by vertebral bodies anteriorly, pedicles laminae laterally, and spines posteriorly. So this is the anterior aspect and this is a posterior aspect, which should be able to identify. Okay. So vertebra, usually the spinal cord ends at L1 in adults, and this is where the spinal cord ends, and from below that conus cauda equina and conus medullaris regions. So we should be knowledgeable about this because we have to calculate segments. And importantly, what are the dimensions of the spinal cord? And it's a bony vertebral column which protects the spinal cord. The spinal cord length is about 18 inches or 45 centimeters. At birth, it is at the level of L3, but as the age progresses, in adults, its tip lies at L1, L2 intervertebral disc level. Now that is the length part. Look at the anteroposterior diameter of the spinal cord. Within cervical region, it is ½ inch. Thoracic, 1/4 inch. Again, lumbosacral, it is ½ inch. In the cervical region also, at C4 level, it is 7 millimeters.
Excuse me, sir. So
But then
actually
because
the
of
slide
the
is
brachial plug,
appearing.
lumbar canal, it will be around 15 to 27 millimeters. And
Excuse me,
whenever,
sir. Can you hear me?
hello?
So actually the slides are blurred, so we're not able to read what is there on the slide.
It's a blurred, and I'm able to see them nicely here. How can I
Sir,
help
can
you?
you please try sharing the screen again if it's possible, because everyone is not able to see.
Okay, and right, okay. So let me see if I can help. Open slideshow. I have to skip. Yeah. That blurred. It's okay, no? You are able. I don't know why it's coming like that. I'll see. I'll stop it. Okay. Okay, friends. Then we'll go ahead to the next slide. You see the segmental and vertebral levels are compared here. It means the bony vertebra, as I said in adults, the spinal cord ends at L1. The spinal nerves, which are coming from the spinal cord, 1 to 7 emerge above the corresponding vertebrae. Remaining spinal nerves emerge below. So that's a point to learn. And look at the transverse section of the spinal cord, and this is where the gray matter of the spinal cord, which is in the center, supplied by the blood vessels, anterior spinal artery is supplying the anteriorly, and this is the anterior portion, and this is the posterior. You can see the dorsal root ganglion, which is the input for the sensations coming from periphery, and so you have a which is motor and a dorsal root with sensory, and both these join to form the mixed nerve, which is spinal nerve. Through the intervertebral foramina, it
No,
comes out
excuse me, sir. So
and
actually, it's still
divides
blurred.
into.
Excuse me, sir. Sir, it's actually still blurred. We're
Yeah,
not
yeah.
able to see anything on the slide.
What can I do? I don't know. I stopped the video also. All of you stop your videos, and if you are seeing on a video, that may help. Yeah. Uh, is it then?
No, sir, we cannot see anything.
No, sir. Sir, it's still
No,
blurred.
no, it is better.
No, sir.
Okay, I think as it progresses, it might. This is the
But can you
problem with the
share this
connection.
presentation with Yuvraj, the one who you sent the meeting ID, so that we can refer it.
People can see the slides, PPT slides on WhatsApp.
Okay, right.
And we can go on with the video.
Right. Then I don't know, discontinue right now. I'll give you later on. You just concentrate now. Okay. So this is the anatomy which we have already dealt earlier, and just keep concentrating. This is only revision before we hit the case, which is our main idea. There are major ascending and descending white matter tracts, the lateral corticospinal tracts, the rubrospinal and lateral vestibulospinal, and so medial longitudinal fasciculus is seen here. So there are sensory, there are motor, and the posterior columns, and this is the posterior funiculi, the lateral funiculus, and the anterior funiculi. So these are how they are divided. The ventral spino-cerebellar, dorsal spino-cerebellar, cortico, these are going up to the ascending tracts. Spinothalamic is another ascending tract. On right side, posterior columns, cuneate and gracilis, and dorsal spinocerebellar, ventral spinocerebellar, spinothalamic. These are all the ascending tracts, and the descending tracts on the left side, lateral corticospinal, rubrospinal, medullary reticulospinal, and vestibulospinal. These are all on the right side. And what's important to know is that all these tracts are in that 1.4 maximum centimeter diameter. That means spinal cord is so small in diameter when you look at microscopic level. So this is this pathology specimen. Here you can see the dorsal funiculus, the posterior horn, and in which the dorsal root ganglion is present. This is the central canal, and this is the intermediolateral column, and this is the anterior horn. Okay, so whatever I am doing in the in middle is the gray matter, where a lot of neurons are present. The outside funiculi contain the tracts, which are white matter things, which are carrying impulses from periphery to central and from brain to periphery. And you can see the tracts which we have discussed. You can see the dorsal ventral spinocerebellar tracts, the ventral lateral spinothalamic tract, and the fasciculus cuneatus, fasciculus gracilis. So some are crossed, some are uncrossed. The spinothalamic tracts are crossed tracts. They enter in front of the central canal. The second order neuron ascends up to the thalamus. That is a crossed one. The posterior columns, they enter to the dorsal root ganglion, they ascend up, they are not crossed. So the corticospinal tract, cerebrospinal, spinal, and reticulospinal tract, they are already crossed at the level of the pyramids in the brain. So in spinal cord, you have you will learn a spinal cord syndrome later, and that's called Brown-Sequard syndrome, based on the anatomy which we have discussed later. And there are sensory tracts and there are motor tracts, and we have already seen, as I said, the superficial sensations, that is pinprick, temperature, and touch. They are conducted from the periphery. The cell body is in the dorsal root ganglion, and the action potentials are coming from periphery and dorsal root ganglion. they are entering the central process and they synapse here. They synapse in the substantia gelatinosa and the rexid lamina about 4th, 6th, 7th, 8th, which we learned in the last class. Second order neuron starts from here, crosses and ascends up as lateral spinothalamic tract. This is carrying the superficial sensations. Okay, that's important. The other proprioception, that is vibration, joint position sense, it is also coming from periphery, and after entering the spinal cord, it is ascending, not synapsing here. It is ascending up to cuneate and gracilis nucleus, and there the second order neuron starts, crosses across as medial lemniscus and ascends to thalamus, where the second order neuron ends and goes to the third order neuron, takes it to the parietal lobe for processing. So that's how these sensations are conducted. The sensations are two, right? One is superficial, the other one is deep sensation. This is very important for you to understand the cases and the pathologies on spinal cord. The motor tracts are coming from above. They are already crossed, the lateral corticospinal tract. And there is one uncrossed tract, that is ventral corticospinal tract. It is a major descending tract. And other things are coming from the brainstem, that is reticulospinal, vestibulospinal, rubrospinal tracts, which are originating in the brainstem and coming down and crossing at the pyramidal level. These are also subserving the function to maintain the tone and posture. So this is what is the corticospinal tract, which we have learned from the motor cortex, the posterior limb of internal capsule, the cerebral peduncle and pons, medullary pyramid, and crossed at the pyramid level to the lumbar and sacral cord. So that's how this, so you can see the coronal section where the cingulate gyrus, paracentral lobule, frontal operculum are seen, and from here the supply of these regions is by anterior cerebral artery, middle cerebral artery, and posterior cerebral artery, and ischemia can give rise to hemiparesis. So these are the other tracts, the rubrospinal tract, which is arising in the red nucleus. You can see the red nucleus in the midbrain, and on the opposite and reaches the cervical spinal cord. What it does is it activates the flexor movements of the arm. The other one is involved in the eye movements. It is coming from the superior colliculus, that is arises in the contralateral superior colliculus, and together with the middle vestibulospinal tract coordinates the movements of the head with those of the eyes. That's the importance of the tectospinal tract. So in a spinal cord pathology, all these tracts are involved, and those pathologies can be compressive and non-compressive. These are the tracts, spindle in the muscles. These are receptors of bone receptors are muscle spindles, which are the intrafusal fibers which are present in the muscles. They are giving rise to the dorsal spino-cerebellar tract, and which ascends and goes to the cerebellum. So that is the dorsal spino-cerebellar tract and ventral spino-cerebellar tract. So these are the two important things that will come. Is it coming now?
No, much clearer.
Now, T1 to L2. This is a sympathetic outflow. The parasympathetic outflow is which subserves the blood. Is important aspect. After entering the spinal cord, ascend up and go to the pons. From pons, it go to the paracentral lobule. So that anatomy we have discussed in the previous classes on spinal cord. So there is a various differential diagnosis. It can be vascular etiologies, infectious etiologies, inflammatory and immune, metabolic, and other materials can give rise to myelopathy, which we will take one after other. So these various pathologies can cause either compressive or non-compressive myelopathy. Spinal cord and meninges can get through a congenital defect in the vertebral cord with the that meningocele. So at the end of the you should always examine a tuft of hair or a sinus, pilonidal sinus, or a myelomeningocele, which will tell that the individual has a problem in the development, and that could be myelomeningocele. And another pathology which we come across in vascular ischemia, epidural hematoma, infections, traumatic spinal injuries, autoimmune diseases, and neoplasm metastasis, complete transection. Whole spinal cord you can see is cut. That means the lower part is separated from the upper part. So you got a spinal level to pinprick, 1 to 2 levels below because of the crossover. And there is paraplegia if it is in the thoracic region, quadriplegia if it is in the cervical region. As soon as the transaction occurs, there is a flaccid areflexic paraparesis or quadriparesis, and slowly after 2 to 4 weeks, the spasticity and hyperreflexia set in. So in acute state, it is flaccidity and areflexia. As the injury is 3 to 4 weeks old, then it becomes hyperreflexia with spasticity. So this is the complete transaction of the spinal cord. We'll see various syndromes. Hemisection. Here you see the pathology is the one side of the spinal cord. Already the fibers of superficial sensations, they have crossed and they are ascending in the spinothalamic tract. The motor fibers have already crossed and they're coming down, and the ipsilateral proprioception is ascending up. So three things you should remember here. The motor is crossed at this level. The spinothalamic is also crossed at this level, and ipsilaterally the posterior columns are not crossed because that first order neuron is going to end in gracilis and cuneate nucleus. So as a result, in hemisection, which we call Brown-Sequard syndrome, there is a contralateral loss of pain and temperature, which is 1 to 2 levels below. What happens on the same side of the injury? Suppose somebody has cut this. Ipsilaterally, there is a loss of proprioceptive function. Ipsilateral UMN findings below the level of the lesion. Ipsilateral LMN findings at the level of the lesion. And if it is a cervical region, you always get a Horner syndrome. So importance of looking at the pupil and partial ptosis. If there is meiosis and partial ptosis and loss of sweating, then you can see that there is a Horner syndrome. So the etiologies are same. You can, last time we mentioned the complete transaction, same etiologies. So this is a Brown-Sequard syndrome. The left side is injured because of some pathology, which we can discuss. We have discussed. And what it gives rise to is loss of all modalities of sensation at the level of the injury. This is a transverse section. So at that level, you get loss of all sensations. And ipsilaterally means same side of the lesion, you have proprioceptive loss, joint position loss, that is vibration loss, and also weakness. Contralaterally, you have loss of pain and temperature sensation. That is because the fibers of superficial sensations after entering the spinal cord cross in front of the central canal and ascend up on the opposite side in spinothalamic tract. That's why you get 1 or 2 levels below this sensory feature. This is the Brown-Sequard syndrome, which hemicord section. Now, suppose what happens if there is a central problem. Around the central canal, there is a problem. What will happen? Same etiologies can cause neoplastic, intramedullary, cord tumors, and autoimmune inflammatory pathologies, and post-traumatic and vascular causes, and the syringomyelia. All these things can affect the central canal. Here, the root ganglion is there, which is getting sensations from periphery. Two types of sensations are coming: superficial, pinprick, pressure, touch, enter, and synapse and cross in front and another. The other sensation that is coming is posterior column vibration, joint position sense, two-man discrimination. They ascend up and go up to cuneate nucleus, and second neuron starts, goes up as middle lemniscus and reaches the thalamus, third thalamus node. So what do you get? You get sensory loss, sensory level with loss of pain and temperature at the level of the injury. Segmentally, at the level of injury, you get lower motor neuron findings, means the myotome that is supplied by that spinal segment shows wasting, fasciculations, and weakness. That is the element findings. If it is a large lesion, you can see the UMN findings below the lesion. That means spasticity, hyperreflexia, extensor plantars. The bilateral pain and temperature loss with sacral sparing. This term will explain. You see laterally. We'll describe it. We have already described in the anatomy class. But again, we'll see what if there is any doubt we can describe. So central cord syndrome is characterized by, at that level, element findings and suspended sensory loss with loss of pain and temperature at that level. If it's a large lesion, you also get the corticospinal tract involvement. If it enlarges, then you get UMN findings below the lesion, and of course the corticospinal or the spinothalamic tract lesions also will give rise to loss of superficial sensations. So that's the central cord syndrome. Now we'll go on to the commissioner. This you can see that this is the central cord syndrome, what we are discussing. This is syringomyelia, which is seen here, and this is the depiction here, and you see the suspended sensory loss. That means here it is okay, here it is okay, here it is not okay. That is a suspended sensory loss of all modalities at the level of the lesion. If the lesion is big, you start human lesions, human signs below the level of lesion. Now there is one more thing that is called posterior column syndrome. Bilateral proprioceptive and vibration sensory loss below the level of the lesion. Absent reflexes because of the dorsal root involvement. There is a sensory ataxia, stomping gait. And if the problem is in cervical region, you may get a Lermit sign, that is bending of the neck with a electric shock-like sensation radiating down the spine. The causes are vascular, infectious, cervical spondylosis, and could be because of delayed radiation effects also can give rise to this type of syndrome called posterior column syndrome. Now, anterior horn cells. See, the Bell Megendie says the posterior horn is totally sensory. Okay. The anterior horn is motor. Okay. The sensory is. So, somebody is asking something? Chart 1.
Any difference in pattern of sensory loss in syrinx and intramedullary lesion?
There is no difference. There is patchy sensation. Okay. So the anterior horn cells are pure motor. That means they are supplying the neuromuscular junction. The nerve goes to neuromuscular junction, right? And these are purely motor. And posterior horns are purely sensory. So anterior horn cell disorders will give rise to diffuse lower motor neuron dysfunction findings, characterized by weakness, wasting, fasciculations. They may involve anterior horn cells, means cranial nerve also can be involved. Those are also anterior horn cells. Infections, paraneoplastic myelitis, genetic and degenerative. All these things are same. Now, if you have a problem of anterior horn cells and corticospinal tract, that means you have a feature of LMN and UMN together, also bulbar involvement, bladder function is preserved, sparing of one of nucleus at S2 and 4. This type of picture is seen in amyotrophic lateral sclerosis or motor neuron disorder. Okay. Okay. So this is another type of spinal cord syndrome where you have seen anterior horn cells as well as corticospinal tracts are involved. In subacute combined degeneration of the cord, you see the coronal section of the cervical cord, which is stained with hematoxylin, eosin, degeneration of the dorsal columns, and combination with that of lateral and anterior corticospinal tracts. Also, they are degenerative. Then subacute combined degeneration of the cord, you will have problems of both posterior columns as well as spinal cord. Okay. lateral corticospinal tract. The spinal cord ischemia is a blood supply. That means if there is a problem, you can see the anterior spinal artery here and the posterior spinal artery here. The anterior cord syndrome characteristically involves UMN findings, which are rapidly progressive, with LMN findings at the level characterized by loss of pain and temperature, autonomic dysfunction below the level of the lesion. Anterior two-thirds of the cord is involved. That means the corticospinal tract, the corticospinal spinothalamic tracts, and all the brainstem originating tracts are involved. In the posterior spinal arteries, there is a problem. You will have only proprioception and vibration dysfunction and global anesthesia at the level of the lesion. So these are the characteristics of ischemic lesions of the spinal cord. So you can see these problems in spinal dural AV fistulas. You can see the sagittal thoracic T2 MRI here. It's a thoracic level dural AV fistula, which you can see the AV fistula here. And flow voids, you can see small flow voids are seen dorsal to the cord, representing the fistula. The fistula results in cord edema, evidence of a high T2C. This is the cord edema which you are seeing in the central. So there is a spinal dural AV fistula which can give rise. This is another vascular pathology of the spinal cord. So right now, whenever disease is there, you have to localize the spinal cord, both in longitudinal direction and also in the transverse direction. If you look at the cervicomedullary junction pathologies, because of tumors or any other region, the weakness occurs in the around the clock pattern. That means it is called Ellsberg phenomena. Ellsberg phenomena, right upper limb, right lower limb, left upper limb. So that is around the clock pattern, Ellsberg phenomena. It is seen in tumors which are pressing on
एक
the
सेमिनार
spinal
चालू आहे
cord.
अर्जंट मी विसरलो तो 20 मिनिटं गेले माझे
And it is a tumor that is pressing at the cervicomedullary junction. If the problem is at the cervical C3 to 5, diaphragmatic weakness comes. If it is above C4, there may be facial numbness in an onion skin pattern. You should understand why this happens. If you don't know, you should ask me at the end. Lower cervical and sumbosacral region problems. There is usually a sensory level at that or one or two levels below. Radicular symptoms, that is radicular pain and reflex abnormalities. Above the level of the lesion, the reflex is absent and they are brisk reflexes below the level of the lesion. So that's how we can localize in the longitudinal direction where is the problem, and depending on the site, you can guess the etiology. Autonomic also, ipsilateral cervical lesion, you have Horner syndrome. Other autonomic signs with more extensive bilateral lesions, bowel and bladder dysfunction, can happen. Orthostatic hypotension and syncope is seen if the problem is above T5. Autonomic dysreflexia with sympathetic storm in traumas, usually above T6. Excessive sweating rostral to the lesion, hypertension, reflex bradycardia, headaches, nasal congestion, cutaneous flushing, triggered by non-noxious stimulus, distended bladder or bowel. So pathophysiology for Ellsberg phenomena, sir, that pathophysiology is lamination of the corticospinal fibers. The corticospinal fibers, which are coming below upper limb, cross much earlier than the lower limb at the cervicomedullary junction, like this. Like this they cross.
माझा सेमिनार आहे अर्धा तास गेलाय ऑलरेडी आणि त्याचं फार महत्त्वाचं आहे नाही जेवायचं नाही मला
I'll describe 1 second. I'll mute everybody. Then I can, yes. Now the lower limb fibers, they come down and cross at lower level. Any lesion that is coming from side will have upper limbs first, then the lower limbs, then subsequent lower limbs, other side, and upper limbs. So it is the lamination of the corticospinal tract at cervicomedullary junction that gives rise to the Ellsberg phenomenon. So autonomic dysreflexia with sympathetic storm, which we have just now mentioned, that is another localization which comes. Okay. Now, conus medullaris and cauda icona, what are the differences? Conus medullaris is the sternal part of the spinal cord. and there will be symmetric saddle anesthesia. The pain is uncommon in conus medullaris, which is very common in cauda equina, which are a bunch of the roots which are traveling down from the conus and to exit through the intervertebral foramina to reach the targets. The human element signs more mild and fairly symmetric in conus medullaris, whereas there are asymmetric element signs in cauda equina. Sphincter dysfunction is early in conus medullaris, very late in cauda equina. These four silent points, salient point, you should remember. Conus medullaris, what is the sensory disturbance difference? What is the pain disturbance difference? What is the motor disturbance that is different? What is the sphincter dysfunction that is different between these two will help you in differentiating the problems. Usually they are mixed problems. Okay. Now you should be able to differentiate extramedullary from intramedullary. Extramedullary means it is coming from the bony canal, and pain is an important aspect. The radicular or vertebral pain, which is exacerbated with spinal movement, valsalva maneuver, occurs when recumbent. There is early spasticity because corticospinal tracts are laterally placed and get pressed very early. The radicular findings and ascending paresthesias and sensory loss are the sensory findings. Intramedullary, on the other hand, is a central pain called funicular pain. The funicular pain is very ill localized, not any type of pain. It is there, but you don't know, you cannot pinpoint where it is. The spasticity occurs late because intramedullary is coming from within outside. Descending paresthesia, sensory loss, sacral sparing on pain and temperature. As these cut spinothalamic tracts ascend, the lamination at the cervical region is CTLS. CTLS means the cervical fibers are placed inside and the sacral fibers are placed outside. So whenever there is a pressure, the sacral region gets involved. In cases of intramedullary pathologies, there is sacral sparing. That's what is sacral sparing, which you should know the lamination. So with this background, we'll go on to the case now, which is a primary aim of this discussion is a 40-year-old individual who is a resident of UP, a right man, is educated up to 10th standard. The information is given by the self and reliability is fair. So you imbibe the particulars of this. There will be questions. Back lower limbs 1 month. Tingling and numbness both lower limbs 3 weeks almost. Hesitancy, urgency of micturition 15 days. Please note down all the points, and these are the main presenting complaints. Backache, weakness of both lower limbs, tingling and numbness of both lower limbs, hesitancy, urgency of micturition of 15 days. Now, the onset of backache, it is acute following lifting of the weight, and weakness is after 1 month, no, subacute, and course is progressive. So you have a problem which is onset of backache following lifting of the weight, right? It's a backache. Let us analyze at mid back, moderate to severe in intensity, localized more to the left. It is aggravated by movements of the back, walking, and relieved by the rest and lying down. Not associated with early morning stiffness, ruling out the inflammatory conditions. There is no radiation of the pain. There is no aggravation on coughing or straining, saying that it is not radicular pain. The characteristic features of radicular pain are it is aggravated by all the maneuvers that increase the intracranial pressure. So let's see some questions here. Why it's not moving? Yeah. it's not moving the slides, right? How do you analyze this patient's backache? What is the type of backache? Is it originating from the roots, bony canal? Is it inflammatory? Is it degenerative? How do you analyze this patient's backache? Anybody? You know, it is types of backache are inflammatory, which is early morning stiffness, which improves on activity, and there will be constitutional features like fever, loss of appetite. The other type is mechanical, which increases on activity. By evening, it is more, and there will be features like that. Okay? Yeah. Somebody is answering. Arising from spine. Okay. Arising from spine. That means you are saying it's a bony pain, right? Now, what is second question? What are the types of pain associated with spinal involvement? What types of when a patient comes to you with backache? You should be able to recognize what type of the pain it is. What are the types of pain which we have discussed, which can come from the spinal cord? Yeah, you can write. You can tell. Raise your hand. What types of pains you get? We have, yeah, that's good. Right, let's see. What's the pain which you are mentioning? That one is funicular pain, one is radicular pain. Okay, the most important is funicular and radicular pains are very important, and you should know what is radicular pain and what is the girdle pain, the local pain. Local pain is the bone. Funicular pain is originating from the spinothalamic tract. The characteristics are it is ill localized, gnawing, dull, boring type of pain. You don't know where it is coming from, but you have a lot of discomfort. The radicular pain is usually in the dermatomal distribution, because you should know the dermatomes. C5 on the lateral left side of the arm, C6 on the middle finger, on the thumb, C7 middle finger, C8 little finger, T1 middle aspect of the upper arm, and T4 at the level of the nipple, T10 at the level of umbilicus, groin, L1. Like that, you should know all the dermatomes. And it is radicular pain in the distribution of the dermatome. It is short, it is shooting, lancinating pain, and it leaves a dull, boring type of pain on the background. But it comes on coming like a shooting pain, and this pain is aggravated by all the maneuvers that increase intracranial pressure, like coughing, sneezing, Valsalva maneuver, because the roots are covered by a sleeve of subarachnoid space bathed with CSF fluid. And whenever you do these maneuvers, the CSF pressure increases and the pain gets aggravated. So the pains are these are the pains which you come across. Okay. Now the second complaint is weakness of the both lower limbs of 1 month duration. The left side weakness is more than the right. There is difficulty in walking fast, climbing stairs, running. Subsequently, he also had difficulty in getting up from squatting position without support. There is mild stiffness, no history of any jerky movements, twitching or wasting. There is no history of weakness in the upper limbs, trunk, neck or respiratory muscles. So the weakness is very well analyzed, and we should register what are these points, and I'll ask you some questions. How do you characterize this patient's lower limb weakness? Anybody? How do you characterize? Is it a lower motor neuron weakness, upper motor neuron type weakness, muscle weakness? Yes, somebody is answering question. Very nice, right? It is UMN. Why do you say it is a UMN weakness? You can unmute yourself and say.
Sir,
Okay.
because there are no fasciculations and muscle atrophy at the upper limbs, no
You
element
should
signs
tell
at
the
the lower
positive
limbs.
points. Positive points. There is stiffness.
Yes, sir. Spasticity.
Stiffness will, yeah, spasticity. Stiffness will tell that it is possible, right? Okay, very nice, very good, good interaction. Upper motor neuron characterized by stiffness, mild weakness, no wasting. Lower motor neuron, you'll have looseness, fasciculations, and marked wasting. Okay, that's the important thing. Now, tingling and numbness of both lower limbs of 3 weeks up to groin level. Left is more than the right. Associated with a band-like sensation just above the umbilicus. He denies loss of any pain or temperature sensation. So let us see, let's have some questions. What are the sensory pathways in the spinal cord? What are sensory pathways? You can tell. We have read, no? How many sensations from periphery are conducted to the brain through the spinal cord? What are the sensory pathways? What are superficial senses are taken by? Proprioception is conveyed by? Yeah, I tell. We said no, the receptors, the free nerve endings, the Merck's discs, Pacinian capsules, and all are present. They are getting stimulated. They are generating action potentials. These action potentials are getting conveyed or conducted to the dorsal root ganglion. That means the nerve cell body is the dorsal root ganglion. The peripheral process is attached to the receptor. From the receptor, action potential is coming up to the dorsal root ganglion. As far as superficial sensations are concerned, there is a synapse from the central process in the dorsal root in substantia gelatinosa or rexid lamina about 6, 5, and 7. And in this synapse, the second order neuron starts, which at the level or 1 or 2 levels above or below crosses in front of the central canal and ascends up to the thalamus as second order neuron. There it synapses, third order neuron goes to the parietal lobe where the sensory information is processed. That is one type of sensation. The other sensation is a vibration and joint position sense, which is very important for maintaining our erect posture and our muscle tone and etc. It is also conducted by the receptors. They generate action potentials. These action potentials, they get conducted to dorsal root ganglion. The central process, unlike in the superficial sensory pathways, it doesn't synapse. It ascends up in the posterior column up to the cuneate and gracilis nucleus at the end of the spinal cord. The second order neuron then arises, crosses to the opposite side called internal arcuate fibers, and they ascend up in medial lemniscal pathways and they reach the parietal lobe for processing. So these are the sensory pathways which you should remember. The spinothalamic tract, lateral and anterior, conducts pain, temperature, and crude touch. The dorsal columns conduct fine. You are clear on this, right? So dorsal column and spinothalamic tracts, that's good. And what are crossed, what are uncrossed, you should be able to remember. Right, this is the funiculus cuneatus and gracilis, the CTLS lamination of the dorsal columns, the CTLS lamination of the spinothalamic, the corticospinal tract, and the spinothalamic tract lamination of the cervical, thoracic, lumbar, and sacral regions of the spinothalamic tract, and which will give rise to the sacral sparing if there is a central lesion. That's the catching word of what the spinal cord pathology is. How do you analyze this patient's bladder symptoms? How do you analyze the bladder symptoms? He's got urgency, frequency, and precipitancy. Or he has got retention of the bladder. And he's not. So he has got an insidious onset of bladder symptoms over 3 weeks. If you know, then what does it tell us? What does this bladder dysfunction tells us?
UMN bladder.
UMN bladder or LMN bladder? Answer. Is it UMN bladder or LMN bladder? You have noted down the features, isn't it?
UMN bladder, because he's complaining of urgency.
Good. So the S1, S2, S3, these are the pathways, and the on-off nucleus supplies the sphincter at the bladder neck, and the parasympathetic supplies the detrusor muscle. Just remember a small child who is a newborn child. In a newborn child, as soon as urine comes from the kidney ureter into the bladder, there is a reflex, and immediately urine is thrown out. And that reflex is mediated at the level of the spinal cord. That's why the infant, he keeps on peeing a lot of times. As the growth occurs, the pontine micturition center starts developing, which sends its fibers to the sacral region of S1, 2, 3, and it provides inhibition to this reflex. So the switch on and off mechanism is at the pontine level, and as the child grows, so it will say that now you can accumulate up to 400 to 500 ml, then only you start peeing. That's another development that takes place as the child grows. And subsequently, this child who is peeing day in day out inappropriately will develop control, because the frontal lobes are the paracentral lobules are also achieving good development, and they exercise control over the pontine micturition center and say that this is not an appropriate time to pee. Just wait for some more time. That's how he achieves. So now you have the sacral spinal region, the pontosacral fibers which are inhibitory, and the social inhibition is from the frontal and the pontine fibers. So whenever the spinal cord pathology is there, it cuts off the inhibitory fibers coming from the pontine center. Thus, the spinal cord, the fiber becomes automatic. It goes on to tract as urine so frequently, he will not. The moment he gets a sensation, he has to point this precipitately urgency. These are UMN bladder. Unlike the LMN bladder, if there is a problem in the S1, S2, S3, and its connections to the bladder, there will be distension of bladder and there will be no sensation. A senseless distended bladder, that is distension with overflow, is characteristic of a lower motor neuron type of bladder. In acute spinal cord injuries, there will be flaccidity. So there will be no UMN or LMN difference. The bladder is totally incontinent. That is called spinal shock stage. Okay, you have urgency, precipitancy, urge incontinence, and so the element bladder, urinary retention with dribbling incontinence, atonic bladder, large bladders, loss of bladder sensation. These are the characteristic features. What is the importance of bladder in cord involvement? What do you think? In this case, backache is 2 months, weakness is 1 month, and bladder dysfunction features almost 2 to 3 weeks. What is the importance of in the bladder as far as intervention is concerned? This is a urgency. What can you tell anybody? What involvement? Anybody is raising hand? What is the importance of bladder? So what happens is it indicates progressive spinal cord compression, requires urgent therapy to prevent irreversible damage. The moment in such a similar case where symmetric onset, progressive neurological dysfunction, weakness, spasticity, bladder features develop, it means the progression to be very rapid, bladder dysfunction is going to set in, and which will be irrevocable. So the surgery has to be done, the tumor has to be removed. Damage. Okay, so now you can summarize a 40-year-old male presented with history of after lifting of AV, followed by subacute onset, urgency of micturition. There is a past history of pulmonary tuberculosis and ischemic infarct in the left MCA territory also, and which I forgot to mention, but now anyway, I'm giving you the details now. So now you give me a 4-tier diagnosis. What is a 4-tier diagnosis? What is a functional deficit in a syndromic name and give to this condition? What are the physiological involvements which his concern, with a lesion anatomically, and what would have problem? Diagnosis and what is the functional deficit this individual? Are you people listening? Say yes or no. Aditi,
Functionally, paraparesis.
Swapnil, all of you absent. Ujjwala, Tishar Gupta. Some of you have to answer. Vijay Gupta. So now let's look at this. Yes, follow. Hello. Yeah. Please. What is the functional deficit? What are physiological involvements? Okay, historically, which part of the neuraxis is involved in this patient? Muscle, neuromuscular junction, radicals, brainstem, brain. Which part? Simplest? Spinal cord is involved. This much answer you should give. Muscle, neuromuscular junction, peripheral nerves, anti-horn cells, spinal cord, and brain. That's how you look at the levels of involvement where this problem is. And the features, there is evidence of a definite spinal level involvement of motor, sensory, autonomic fibers, lower motor neuron at the site of the lesion, upper motor neuron features at the below that. That's why we call it a spinal cord. Myelopathy case. What are the types of myelopathy and important etiologies? How do you classify myelopathy or spinal cord disorders?
So compressive and non-compressive myelopathies.
Right, very good. Compressive myelopathies can be extradural, intradural, extramedullary, intramedullary compressions. Okay. Non-compressive got various etiologies. That is inflammatory and autoimmune, infectious, toxic, nutritional, and various other causes are there. So remember, they are asymmetric in onset and progress, like in this case, backache, weakness, blood infections. Whereas non-compressive are static, sudden in onset, symmetrical. In compressives, there will be bony deformity like gibbous, spinal tenderness, paraspinal collections, etc. In non-compressive, you don't see such things. Bony tenderness or spinal tenderness is present on examination in compressive, it's absent in non-compressive. Root pains are characteristic features in compressive, whereas in so important differences and causes of infections, malignancies, PIVD, and myelinosis, non-compressive infection, post-infectious, nutritional, paraneoplastic, toxic, degenerative, and vascular. These are various etiologies. Though you remember two things which I tell for extradural compression. Extradural compression is mostly by infections, that is tuberculosis, important, epidural abscess, and bacterial infections, that is pyogenic infections, and fungal infections. That means bony osteomyelitis can be important cause for the extradural compression. We are at the level of the extradural compression. After infection, you get tumor. The tumors can be benign, which are very rare tumors, and malignant. In malignant, it can be primary malignancies, external compressions, metastasis, and the metastasis can be from prostate, from the kidney, the breast, and thyroid and melanoma. These are the lymphomas. So these are the metastatic tumors that are present at compression. The primary bone malignancy compression compression causes. Intradural extramedullary, that means between the spinal cord and the bony canal, there can be meningioma, schwannomas. And basically, they have radicular pains at the onset. And intramedullary, you can have the ependymomas and the gliomas, tuberculomas, cysticercosis. These are the important causes of the intramedullary. And so these are the compressive myelopathies. How do you determine the upper level of the compression? Where? In examination, you have conducted, you have taken the history, you have examined. And how do you know that at what level compression is there? So that you can do imaging of that level instead of imaging the whole spine. What are the features which will tell you? You should have a sensory level, loss of spinal reflex at that level, and fasciculations, element signs. So one thing you learned is that element signs are at the level of the lesion, UMN signs are below the level of the lesion. So this is a vertical localization. So suppose if it is C5 problem, you will have wasting of deltoid muscle, fasciculations, and possibly a loss of sensation on the lateral aspect of that. And in the lower limbs, you will have stiffness and increased reflexes, extensor plantar, and abdominal reflexes will be absent. So that's the type of localization which will help you. What is the importance of testing sacral region sensations, which I have already explained? Somebody tell. You have to test the sacral region sensations. What is the importance?
Intramedullary can exactly.
What will happen in intramedullary? Sacral?
At least sacral sparing
will be there. In cervical region, if there is a compression from intradural extramedullary, it can cause pressure on the sacral region. So sacral sensation will be involved in that region. So sacral sensation lost in the Corticospinal syndrome, and sparing is seen in intramedullary lesions also. What are the types of spinal cord syndromes which we have already seen? You got the complete cord transection, Brown Sequard, central lesions of syringomyelia, posterior column syndrome, that is subacute combined degeneration with Corticospinal tracts, the posterior column syndrome, tabes dorsalis, anterior-horn cell syndrome, combined anterior-horn cell and pyramidal tract syndrome, that is ALS, anterior spinal artery occlusion. So these are the difference. So differentiate between intramedullary and extramedullary lesions, which we have already studied. This is a subarachnoid space. This is spinal cord. You can see that this is the covering, that is durameter. This is a vertebral body that is seen. This is a lamina, and you can see the intervertebral foramina and the dorsal nerve root that is coming out. This is the intervertebral foramen that you are seeing, and you can have impingement on this nerve causing pain. So this is an important diagram to remember. The extramedullary intermedullary differences can be studied in this fashion. The pyramidal signs are very early and extramedullary, but they are late in intramedullary. The element signs are at the level of the lesion in the extramedullary compressions. Intramedullary, they are widespread. Root pains are very common in extramedullary. That means it involves both extradural, intradural, extramedullary, and intramedullary, they are very rare. The funicular pain is characteristic of intramedullary, not seen in extramedullary. Dissociative sensory loss is present in intramedullary. It means the source of pain until columns is sensory loss. Sacral sparing is a feature of intramedullary, but it's absent in extramedullary. Bladder bowel dysfunction is very early in intramedullary and late in extramedullary. Local pain is always a feature of extramedullary, but not intramedullary. These are the main differences. Okay. So these are the difference between the extradural and intramedullary. Right. The investigations in this case has shown ESR to be 12 mm, hemoglobin 15.4, and the TLC and DLC count showed no abnormality as well. Platelet counts are also normal. The blood sugar is normal. Urine RE and AD, sugar fasting and postprandial also normal. The urea, creates, and bilirubin, and ALT, AST, ALP, prothrombin time, sodium, potassium, chloride, calcium, phosphorus, HIV 1 and 2, all are non-contributory. The urine for Benz-Jones proteins is negative. Serum electrophoresis for ruling out the primary important malignant bone tumor extradural compression, multiple myeloma is negative. X-ray skull and pelvis are normal. Bone marrow examination also was done as normal. The prostate specific antigen tumor marker is negative. The prothrombotic workup is sent up but it came as negative. Now look at the radiological investigation. Hereafter there will be no questions, only I'll teach you what is the radiology in this case. The chest X-ray is unremarkable as such, but you can see some type of globularity seen. It could be a tumor, which you can see, and you can see that some shelving is seen here, and you can see some amount of abnormality that is coming up in the X-ray, and you can see that in the MRI, T1 weighted image, which is important for anatomy. You can see there is a tumor which is and which is marked here. You can see that, and that is a tumor which is very big in this. How do we diagnose? And we have to either cut it or do a biopsy of this and see, because already the bladder is getting involved. So you have to remove this tumor and test it. And this tumor in axial sections is the spinal cord which is depressed, because tumor which is so big looking. This is the spinal cord which is getting compressed. You see that. And you can see the still image. You can see the tumor which is occupying on the left side and is a problem which this tumor has to be removed. So differential diagnosis of, look at that, could be a primary bone tumor, that is secondaries and from gastrointestinal tract or kidney, or is it a giant cell tumor, aneurysmal bone cyst, and infectivity could be tuberculosis. So any of these possibilities are present in this case, and he has got an old infarct in the brain, which we mentioned, and so what we did was a USC guided FNAC, which has shown this type of giant cells. Giant cells have been seen in this FNAC specimen of this tumor, and the possibilities of giant cell tumor, aneurysmal bone cyst, and spinal angiography to delineate the vascularity of the tumor was done, and there is a preoperative embolization of the tumor to reduce the bleeding during the procedure is done, surgery, and that is the definitive management. And this is the embolization which I was mentioning. To reduce the vascularity of the tumor, you embolize the blood vessel feeding the tumor, and then that is left D9 intercostal artery has been embolized, and the tumor vascularity has been reduced and it was removed. This is the tumor blush which you can see before the embolization, and post embolization you can see the blush has disappeared, and debulking of the tumor mass and cord decompression, laminectomy D9 and D10, and post-operative period is uneventful. So the histopathology is again the giant cell tumor, which you can see a lot of giant cells that are present inside, and you can see them, the group. This is the histopathology of the tumor, which is reported as giant cell tumor, uniformly distributed multinucleate giant cells, focal fibrohistiocytic areas, reactive bone at the periphery is seen in this these slides. So final diagnosis is giant cell tumor. So the final giant cell tumor at D9, D10, it's a compressive myelopathy at D9, D10. Pulmonary tuberculosis is old, so it has will be done. And aim of this presentation is to teach you how to approach a case of myelopathy and discuss briefly the anatomical and physiological aspects of spinal cord, and to say that not all compressive myelopathies are tubercular, like this case, which we thought tubercular turned out to be giant cell tumor. A rare presentation of giant cell tumor is presented. Right. So that's all from the case discussion point of view. Any questions? How did you like the case? Did you learn anything?
So could you again tell about dissociative anesthesia?
Dissociative anesthesia means at the level of the spinal cord, like I'll show you the picture and I explain to you. That's why I touched upon the anatomy in the initial stages, because there will be doubts. See here, the dorsal root ganglion is sending fibers inside the central process, which is conducting the pain, temperature, and touch sensation, is synapsing here and sending its fibers across the central canal, and these fibers ascend up like this in spinothalamic tract. The posterior columns are coming, but they are not synapsing here. They are not crossing, but they are ascending up to cuneate nucleus and gracilis nucleus. These two are the sensory. The motor fibers which are coming are already crossed at the level of the pyramid in the midbrain, I mean the medulla, and they are coming down. They are crossed already. So in the dissociate anesthesia, if there is a problem here, the pain and temperature sensations are lost because they are crossing in front of the central canal. The posterior column sensations are not lost because they are not crossed, they are ascending ipsilaterally. Is it okay? Is it clear?
Yes, sir. Thank you.
Anything else? Shall we close? Okay. So if there is any doubt, you can talk to me anytime. And that's all from my side till next week. We may have another case of spinal cord also. So keep reading spinal cord.